oral thrush. Starting from the mouth till the anus, there are so many problems. So the common things we see in palliative care is oral thrush, stomatitis, dry mouth, nausea, vomiting, constipation, diarrhea, and intestinal obstruction. So today we'll be learning in detail about nausea and vomiting. Okay, it is very important. It is very common. So we'll be learning in detail about it. Next slide. Next slide. So see, nearly 40 to 70 percentage of patients with advanced cancer has nausea vomiting. It's not a small number, right? 40 to 70 percentage is not at all a small number. Most of the patients will be having pain. We see a lot of patients with pain, but associated with it, mostly they'll be having this nausea and vomiting. And the management involves accurate assessment. Various mechanisms are involved, and we are targeting a drug therapy rather than prescribing the same antiemetic. So the goal of our class, usually what we do, most of us will be knowing one or two analgesics, and whenever a patient comes to us and say that, yeah, doctor, I'm having nausea, you'll prescribe that. We are not doing anything. We just know that antiemetic is commonly used. The most common is Emiset. Okay, we use it very always. We use like ondansetron, right? So the goal of this class is to understand that nausea and vomiting the causes are very different. The mechanisms are different and the treatment is different. If you treat it properly only, it will get subsided. We can control so much part of it. Okay. So we learn in detail. Next slide. So, the problem, what is the problem? We said that we already said that 40 to 70 percentage of patients have this. What happens? What happens when a patient is having nausea, vomiting for a long duration? Think about yourself. You're having, like you feel nauseated for more than like 1 or 2 days. It is very difficult for these patients. It will be like weeks. It will be by like months. They'll be having nauseated or they'll be having continuous vomiting. So it will affect the daily function is affected with poor quality of life. And what happens sometimes, we know that most of the time, the patients who are having malignancy, they'll be receiving chemotherapy, and what happens following chemo, post chemo, they'll be getting like severe vomiting. What happened? These patients will stop taking the chemotherapy. Stop it. So what happens? There will not be a compliance to the treatment. The patients will be stopping the treatment only because of this problem, and there will be no compliance to analgesics. We know that we give pain medications. If the patient is having like nausea, vomiting, how can they take tablets? They'll be telling, doctor, I'm not able to drink a sip of water. Then how can I take all these medications? What happened then? They'll not take pain medications. They'll have pain, and everything will aggravate. So that is very important. Okay. And see, like poor fluid and oral intake, family will also be in distress. Think about your family member. You have to, every time you have to put yourself in that situation and see. It is very difficult for us to see someone having this nausea and vomiting for a very long duration. Okay. Next slide. So let's start by understanding. So our goal, what is our goal? Our goal is to stop or reduce the symptom frequency. Most of the time we won't be able to stop, but at least we can reduce the symptom. Thereby, we can establish a compliance to the treatment, and we can enable the analgesic medications to give like to be given continuously, and thereby improving the quality of life. So this is our goal. Okay, we are going to understand what is the cause of nausea, and we are going to treat it accordingly. We know the importance, right? What it causes. There will not be a compliance to the treatment. Patients will be stopping treatment. Patients will be taking all other drugs, and they'll be in distress. Okay. Now, so we'll start with a few basics. Okay, what is emesis? Emesis means it's a vomiting. It means it's a biological defense mechanism. It is a protective reflex to remove toxic or harmful substance from the body after ingestion. I have shown the picture of a chameleon here. See, chameleon has its own property to protect itself from danger by changing its color, right? So our body is also made in such a way that if something toxic substance enters our body will emit it out, or it will the patient the we'll vomit it out. That is a protective. So it's a protective reflex. But what happens when this protective reflex becomes like increases or unwantedly it become activated, it will become a problem. So that is vomiting. Okay. And now next slide. Now the phases of emesis. So see, the patient will be having the nausea. What is nausea? Nausea is an unpleasant sensation or imminent need to vomit. The patient be telling there is something behind my throat. I feel there is something in my stomach, and it's a unpleasant sensation. They'll be that will be most of the time it will be proceeded before vomiting happens. The patient initially will be having a nausea. Now, retching. It will come out. The spasmodic contraction of the diaphragm. There will be contraction, recurrent contraction of diaphragm and abdominal muscles against a closed glottis. The patient will be like, oh, they'll be keep on, they'll be having retching. And third one is the vomiting. That is a forceful expulsion of gastric contents. The thing will come out. The other two, sometimes it may not be associated with vomiting. The patient will be continuously having nausea only. Sometimes there'll be patient will be having only retching. They'll be keep on retching. And finally, it will be vomiting. Okay. And the last one is regurgitation. Regurgitation is something that a food is brought back to mouth without any contraction. We see in babies, right? We give milk and the milk will come out through their mouth. That is called as regurgitation. Next slide. So first you have to know that, yeah, we have already told nausea is an unpleasant sensation in the back of the throat, which proceeds vomiting, but may not resulting in vomiting always. You should clearly understand that some patients will only tell they'll have nausea, they don't have vomiting, but that has also to be taken into consideration. Okay, next slide. So the first thing is that you have to clearly clarify whether the patient is having nausea, vomiting, retching, or regurgitation. You should be able to differentiate each. When they tell the complaint, you should be able to ask them clearly what it is. Is it nausea or is it retching, vomiting, or regurgitation? Everything is different. Okay. You have to record it properly. Clarify. Next slide. So now we'll be discussing about few types of vomiting. Okay. Just see this acute vomiting. This happened when the patient takes some food and the vomiting happens like few minutes or hours after taking medicines, like anything, or and resolves within 24 hours. That means when the patient is having food poisoning, the bacteria will produce a toxins and we'll get the nauseated and this all kind of vomiting feeling within few minutes to hours. We have studied, right? And it resolves within 24 hours. But the second one, delayed. Delayed is a common one which we see in palliative. That sometimes, most of the time, the patient will be taking a chemotherapy and they'll be complaining that after 2 days, they'll get vomiting and nearly it will take up to 72 hours. Like it will last up to 72 hours. So this is very common. Hmm. Now, breakthrough vomiting. Okay, you have given medications for vomiting. Okay, in spite of that, also the patient, if the patient is getting like 1 to 2 few episodes of vomiting, that is called as breakthrough. That is, see, occurring despite antiemetic treatment. And now the next one, refractory. You have given medication, but the patient is continuously vomiting. Nothing is helping. You are giving one type of medication, you are giving another type, but nothing is working. So refractory vomiting is unmanageable with the current medication. Hmm? And the last one, all these three things you have must have heard, like acute, delayed, breakthrough, refractory, and all. But look at the last one, something called as anticipatory vomiting. Have you ever heard about it? It is not very common, but you might have heard about it. At least few people might have heard. I'll give you an example of anticipatory vomiting. See, one patient is planned for chemo on Friday. Okay, and the family member is coming and reporting to you, doctor or sister, please, this patient is having vomiting since my husband is having vomiting since Thursday. His chemo starts only on Friday. He receives chemo only on Friday, but he starts getting vomiting on the day before getting chemo. How does that happen? Is he faking? Is he acting? People will come and ask you. So you should be able to tell that there is something called as anticipatory vomiting. Hmm? That means it's a conditioned response prior to chemotherapy. The thought of, I will explain what is it. The thought of getting vomiting or having vomiting after chemo, this patients will like keep on having this thought in mind. Okay, I'll get like vomiting after chemo. So this thought anticipate and they can have vomiting. This is there scientifically, it is there. Okay, so you should be able to tell them, see, this is there, this is something called as anticipatory vomiting. Okay, so these are the five types of vomiting. When you document, you should be able to tell what it is it an acute, is it delayed, or is it the breakthrough, is it refractory or anticipatory. Okay, next slide. Now we'll just see the few causes of vomiting. So today we'll be discussing more about the types of vomiting which we usually see in palliative care. There are a lot of causes for vomiting. Okay, but we are not going into everything in that. We are just discussing the common things which we come across in palliative care, the causes of vomiting we see here, and the management done here. Okay, next slide. See, chemically, you can just read through this slide, okay? Chemically induced nausea, like drugs which causes nausea, vomiting, like opioid, antibiotics, cytotoxic drugs. Toxic drugs means chemotherapy drugs, okay? Toxins like food poisoning, ischemic bowel, gut obstruction, metabolic organ failure. In cases of gastric stasis, anticholinergic drug, the gastric stasis will be affected and there'll be no movement. The patient will have gastric stasis and will get vomiting. Other like opioids, ascites, peptic ulcer, all these things can cause gas. The motility will be affected. Now the third one, stretch or distortion of GI tract, constipation, intestinal obstruction, mesenteric metastasis. All these are very common, right? Serosal irritation due to liver mets, ureteric obstruction and all. Then, irritation of GI tract due to infection and drugs. Raised intracranial pressure, very common, right? Cerebral edema, those patients having space occupying lesion, brain malignancies, metastasis to brain, they have vomiting. That is because of the increased intracranial pressure. Okay. Movement associated, vestibular disorder, and anxiety induced, that is our anticipatory vomiting. So these are the different causes we learned little by little in detail in the coming slides. Next one. Okay. So now we have understood a little bit about the causes and the types of vomiting and everything. Now we'll go into the management. How are we going to manage this? But the first thing is what most of the people who come to us, they don't most of them expect that we should like talk to them. Simply writing, when we go and tell them, see, I'm having vomiting, you just give a medicine and you're sending them away. That is not right. We should be able to talk to them. We should be able to understand what type. We should be able to talk with them for some more time. So in that way, we can add some non-pharmacological measures also. We can tell them, other than just giving some medicines, we can ask them to do certain things by themselves so that will help in reducing all these kinds of nausea and vomiting. Next slide. So the usual things we tell them is avoid foods which precipitate nausea and vomiting. For example, if someone is coming and telling you, see, my mother is not taking rice. She gets nausea. She's a cancer patient and she's not able to eat rice, but she's not eating anything. Doctor, if she don't eat, she'll become sick. No, so I'll always force her. Is it right? No, if the patient is not liking it for a certain reason, we can ask them, please don't force feed the patient. She's getting, that nausea gets precipitated when she see rice. For her, it is like that. So you should be able to tell them, avoid foods which precipitate. For them, for each person, it will be different. So you should be able to tell them, don't force feed. Don't like force them to take the food which cause them nausea. Okay, calm and reassuring environment away from the sight and smell of food. Sometimes they'll be telling the smell of food, that's the smell of fish is causing me the problems. So you should be able to tell them, avoid that. Okay. Fresh air, and nurse in the upright position and control of malodor. See, this controlling malodor is very important, right? Because most of the time patients having colostomy or a fungating tumor, If you ask them, like if you ask them the problem, why you having nausea, they'll be telling that this smell is causing the problem, doctor. This is, I can't eat the food. I can't eat food because of the smell. So if you don't ask about this, you will be just knowing that he's having nausea, vomiting, and you will give some medication. That will not work. You have to take this into consideration. Controlling malodor, we'll study in wound management, right? We give Metrogel and we give wash with Metrol. We should be able to we use charcoal and all. We have few many things to control odor. So you should be able to ask them, do you have this problem? Is this colostomy smell causing you this problem? Might be that. If you correct that, patient might take little more food, not just giving some tablets. Okay, next slide. And dietary modification. You can ask them to take frequent small meals. Instead of taking a bulky amount of food at one time, forcing them to eat so much food at one time, you can tell them you can take small meals. And most of the people will not be taking any junk food and all, but still avoid fatty, sweet, too much spicy, and carbonated drinks. And most important is no force feeding. Okay, you should be able to convince the caregiver. Next slide. So these are the few things which you should be able to talk with them. You should be able to calmly tell them. People like they'll become very much reassured when you tell all these things rather than prescribing few medications. Now coming to the pharmacological measures. This is very important, okay? This is a little bit confusing. You have to listen very carefully from the beginning, okay? Then only you'll understand the concept. There are few things which you should be able to differentiate, okay? Let's start. The pharmacological measures. So, for anything to happen, if you just have to move your fingers also, what should happen? Your brain should decide, right? Like that, if vomiting should happen, something in the brain should decide it. So we have a vomiting center in the medulla of our brain. Okay. Where vomiting center controls vomiting. Okay. Next slide. So there are so many stimuli which stimulate the vomiting center. So I'll have number it is three. From the first one is a peripheral area. Peripheral area means from our GIT, from the gastric mucosa and other parts of GIT. That is a peripheral area. Second one is a sensory stimuli. We have two sensory stimuli. One is from the cerebral cortex. Cortex of the brain is here. Cerebral cortex, and from the vestibular apparatus. We get stimuli from here also. And the third one, which is a chemoreceptor trigger zone. That is the third one. So this three, totally four places you have to remember. I have shown picture in the next slide. So this should be there in your photographic memory. Okay. You should save this picture in your memory to easily understand the concept. So the four things, starting from the GI. Look at GI. There are so many receptors there. 5-HT3, D2, NK1. That is the first one. From the GI, the stimuli goes to vomiting center and the patient vomits. Next one, the cortex. From the cortex of the brain, the stimuli goes to vomiting center and the patient vomits. Now the third one, CT is set. That is a chemoreceptor trigger zone. Look, it is a zone. Zone means there are a lot of things in a small place. There are so many receptors in the chemoreceptor trigger zone. That's why it's called as a zone. So from the CT, impulses are sent to the vomiting center and the patient vomit. And now the vestibular system from the ear, which maintains a balance. The impulses are sent. See, there too, you have two receptors, M1 and H1. All these 5-HT3, D2, or everything, these are receptors. Okay. So we'll discuss one by one. So first one is a GIT. Coming to the GIT. Next slide. So, you know what happens when a patient receives a chemotherapy? The chemotherapeutic drugs acts on the gastric mucosa. You know, we are discussing about the first thing, right? The stimuli which is going from the we are discussing about the stimuli going from GI tract. So the chemotherapeutic cytotoxic drug, these things go and destroy the gut mucosa. And from the gut mucosa, the tissue damage, they release serotonin. This is very important. The release of serotonin from the gut wall. Hmm? And this will act on the This serotonin is called as 5-HT3. Okay, you have seen that 5-HT3 is serotonin. So this released serotonin through the vagal afferent reaches the CT set of the brain and stimulates the serotonin receptor in the CT set. We told no, CT set have so many receptors. So from the gut wall, the serotonin is released and it will act on the CT set. And CT set in turn stimulate the vomiting and then results in vomiting. So this is the cause of vomiting when a patient takes chemotherapy. Understood? Okay. So what we can do to prevent this kind of vomiting? Next slide. We know who is causing the problem here. We know from the gut mucosa, serotonin is released. So in order to stop this vomiting, we can give a serotonin receptor blocker, right? So the example of a serotonin receptor blocker is Cetron. That is our ondansetron, the common brand which we use, Emised, right? So that is the reason why after a chemo, a patient is given ondansetron for few days. We know that the patient develops a delayed kind of vomiting after chemo. So to prevent that, we know who is causing the problem here? Serotonin. So we give a Cetron, that is ondansetron. So now you have understood GIT. Now coming to the next one. Have you ever thought of you? I know you all might have been posted in some ICU, post-op ICUs and all. So what happens? Why does those patients get? Very commonly we see that post-operative in the area, the patients will be getting vomiting and all. What is the problem? You know, during the surgery, these anesthetists, no, they'll give pain medications like opioids. During surgery, there will be administration of opioids. You know what happened? Opioids stimulate the D2 receptor in CT set. Again, another receptor in CT set and new receptors in CT set. And that causes vomiting. So that is why post chemo, like post operative patients, when they have resulted, most of the time we will be giving either metoclopramide or domperidone. So you should be able to when our patients are taking opioids, also we give dopamine antagonist. Okay, D2 receptor is dopamine receptor. Understood? Okay. This is the reason why in post-op patients they develop nausea, and this is a medication we give, dopamine antagonist. Next one. So now the vestibular, the third one, the picture of the ear shown. You know what happened? You know, when we travel to a hill station, we get motion sickness, right? And from there, what happened when a patient have motion sickness? Uh, One second, sorry. So when a patient has motion sickness, histamine and acetylcholine is released from the vestibular apparatus. So what have we what we have to do? We have to give something against the histamine. That's why we use a antihistamine there. Understood? So everything you should understand the cause of vomiting and the causes and the mechanism is different. So we have to adjust our medications accordingly. Next slide. Now, the fourth one, the cerebral cortex. What happened? So our cerebral cortex, what controls our cerebral, the taste, smell, sight, and memory, everything is stored in the cerebral cortex, right? So when the cerebral, when we get a bad taste, when we get a bad smell, when we get a bad sight, a bad memory of getting vomiting after chemotherapy. So the cerebral cortex is stimulated and the vomiting center is thereby stimulated and the patient gets anticipatory vomiting. So this is how it works. So what we can do? Will our ondansetron help here? No. Why? The patient is the vomiting is caused due to the action on the cerebral cortex. So something we have to suppress the cerebral cortex. So what we give? We give benzodiazepines. Understood? So the management of anticipatory vomiting is not ondansetron or any other antiemetics. We give benzodiazepines. So you should be able to know the cause of this problem. Okay. Next slide. So in short, We have already discussed. I'll repeat it. When a patient gets chemotherapy or when a patient is taking anesthesia drugs like fentanyl or morphine during the surgery, or when a patient gets opioid during our treatment, what happens? The chemoreceptor trigger zone is stimulated. What happens there? There are a lot of receptors there in the CT set: dopamine, 5-HT3, opioid, neurokinin, and H1 receptor. So, according to the cause, we block the receptors and we reduces vomiting. Understood? Hope you are understanding it. Are you able to follow? Can you say yes or no?
Yes, ma'am.
Yeah, okay. Okay, fine. Okay, next slide. So the same thing in briefs, the sight, smell, taste, the cortex of fear, anticipation. What happens? The cortex is stimulated and the vomiting center is stimulated. And then what happens? See, benzodiazepines are given for anticipatory vomiting. Okay, next slide. And now we learn about few drugs, the examples of these drugs. Okay. So the M1 receptor, from the vestibular system, the M1 and H1, right? Acetylcholine is written as M1. Antihistamine is it's H1. So the examples of drugs when we have like vestibular disorder is or blocking the M1, we have hyoscine dicyclomine. For antihistamines like promethazine is used. Then dopamine antagonist. What is dopamine? We have already told. Metoclopramide and domperidone. Serotonin like receptor blocker is Cetron. Example is ondansetron. Neuroleptics is something which directly affects the brain. That for the example is chlorpromazine and haloperidol. Haloperidol is very important. We use it very regularly. We'll discuss in further slides. Okay. And substance P example is aprepitant and rolapitant. Just for your information, that they are newer drugs. So the common ones we use here is metoclopramide, cetrons, haloperidol, hyoscine, promethazine. All these are commonly used. Okay, next slide. Now, this is in short, this is actually a complicated slide, but look at this slide, you will be knowing this. Look, from the higher this is a summary of what we have told now. From the higher cortical center, memory, fear, anticipation, vomiting center is stimulated, vomiting reflex. Now, the second one, by when we give chemotherapy, anesthetics, opioids, CTC is stimulated, and we get vomiting, the vomiting center is stimulated. The third one, from the stomach or small intestine, what happened? From the gut mucosa, when there is a tissue damage, the serotonin is released. It will affect the CT set, receptors in the 5-HT3 receptors in the CT set, and vomiting goes. From the labyrinth, from our vestibular apparatus, what happens? Acetylcholine and histamines are released, and that causes vomiting. Understood? Okay. Next slide. So in reverse, think back. So who the stimuli of vomiting pathway? We already know the chemoreceptor trigger stone is stimulated by, we know what, opioids, because they have mu receptors and D2 receptors and all. Chemotherapeutic drugs, we know that serotonin causes and it will affect the chemoreceptor trigger stone. Now, few other things I have already told. Biochemical. What is that? Biochemical. Increased level of calcium or renal failure. The patient is having hepatic failure. What happens? This will directly stimulate the CT cell. We know that in palliative, not only we have cancer patients. In ICU, we'll be seeing patients with uh, liver failure, with CKD, uremia, all these conditions, there'll be increased level of all these urea and all, right? So this will directly affect the CT cell. So we will learn that haloperidol has the efficiency to act on CT cell for blocking this. When a patient is having vomiting due to liver failure or uremia or renal failure, the drug used is haloperidol. We learn later. I'm just telling it here. Okay. So when a patient is having all these kinds of failure, and that when that affect the CT set, the drug given for those kind of vomiting is haloperidol. Okay. Sepsis, radiotherapy, and all they stimulate the chemoreceptors. So now, vestibular apparatus, we know that tumor, opioids, these can also trigger the vestibular apparatus. Now, cortical, we already know anxiety, and one more thing. In the cortex, you have to learn one more thing. That is ICP, raised intracranial pressure. We know that when some tumor is there in our brain, when we get some brain metastasis, or when we get a CVA, and there is accumulation of blood in the brain. When the patient get CVA, what happens? The cortex is affected, right? There will be increase in pressure, and sometimes there will be vomiting. Now, from the periphery, we have already told radiotherapy, chemotherapy, GI irritation. I'm just telling it, just revising. Okay. Next one. So now we know few drugs and all. We have learned few drugs. Now we are going to implement it. Okay. So whenever you give a drug, that should be according to patient's condition and preference. For example, most of the time, most of the patients coming to you, they must have gone to so many places, like they must have received so many chemos, or they already have undergone so many dialysis and everything. They have got so many pricks and they'll be tired. They're coming to you and they're telling like, doctor, I'm having vomiting, I don't want any injection. Can you force them? No, 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 you can take only injection, you can take only IV. No, that is not there. You can try oral drugs also, right? If the patient is telling that I need only oral medication, that is allowed. That can be given. Okay. So you should always ask. But if the condition is reverse, the patient is not able to take any food orally, then you can directly go for IV. Hmm? So you should be able to know that oral route is the best and easiest. The patient can simply take it without any pricking and all. You can send the patient back home and giving this drugs, not just admitting the patient always. And if the vomiting is severe, you can give IV, IM, or subcutaneous. Suppository, sublingual, transdermal patches are also available. So you should be giving them the preference. You should be asking the patient like, how are you? Are you comfortable? Which way you are comfortable? Next slide. And the goal of this class, the treatment should be always mechanism based and not generalized. Next slide. Next slide, please. Okay. So now tell me, we have already told so many things. You will be knowing certain drugs which will be causing vomiting, no? Just tell me few drugs which you commonly see causing nausea and vomiting. Just unmute and tell few drugs, very common drugs. We know if we give that medication, the patient develops nausea and vomiting. Can you tell something?
5-fluorouracil. 5
Sorry?
5-FU.
Okay,
5.
okay, okay. Ah, oh, that is a very, that's not very common, but still you told. Very good. Okay. Then, yeah, okay, very good. Tramadol. Tramadol is, yeah. Tramadol, what is tramadol? Tramadol is an opioid, right? Okay. Opioids. Then, the common one, the very common one. Nobody here has given NSAIDs? Yeah, I'm not given. Yeah, antibiotics. Antibiotics is there. NSAIDs, right? So these are the common drugs which causes nausea and vomiting. You should know that these drugs can cause nausea and vomiting, and always you should prophylactically give antiemetics whenever you like opioids. Whenever you give opioids, you should be able to give antiemetics prophylactically. The cause of nausea and vomiting when we take an antibiotic or NSAID is that it causes gastric irritation, right? So we have to give a pump inhibitor. Hmm? So in opioids, we know that today we'll be learning about opioids. So how opioids act? It directly activates on CT cell. You should be knowing about the mechanism. NSAIDs, it will cause acid stimulation and all. That is why it causes gastric irritation. So we should give a PPI. Okay, fine. Next slide. So just I told before, right? Uremia, hepatic failure, ketoacidosis, hyperglycemia, toxins. All these conditions we can see in a patient who is admitted in ICU, right? Sometimes they won't be having malignancy, but having a vomiting, which is not controlled with the usual medication. So you should be able to tell them that, see, the mechanism causing the mechanism of vomiting in this case is direct stimulation of CTZ, and you should be able to give a drug which is against against the CTZ, and that is mostly it is haloperidol. T is haloperidol. Okay, fine. Next slide. Now, in raised ICP, this is a different scenario. Okay, whenever you get wherever you have a tumor in the body, there will be some amount of peritumor edema. You know what is peritumor edema? Peritumor edema means there is some amount of edema around the tumor. So if the patient is having advanced malignancy, chemo is not working, and like the compression, the nearby structures or nerves are getting compressed, and it is causing pain. So what we can do? We can give steroids. Steroids are very helpful in reducing the peritumor edema. That is also in case that they're in the problem with raised ICP. When a patient is having raised ICP, there is increase in pressure in the brain due to the tumor. You maybe you not be able to reduce the tumor by giving chemo and all. But what we can do, when there is increased pressure in the brain, the patient has nausea and vomiting, projectile vomiting we call it as, right? So raised ICP, we can give steroids there. Instead of giving, a patient comes to you with liver malignancy with metastasis to brain. You know that the report is there with you. All the patient is having showing all the features of brain metastasis. He is having nausea and vomiting. You should be able to give a steroid. That will help. There is an increase in peritumor edema around the brain, and if you give a steroid, that will reduce. Simply giving a ondansetron there may not help. Okay, so this is a different scenario. Raised ICP, where patient is having primary or secondary brain tumor, you can manage it with steroids. Also, radiotherapy helps when brain tumor. For reducing the intracranial pressure or size of the tumor, we give radiotherapy. So you can suggest that for controlling nausea and vomiting, not just our antiemetics. Okay, next slide. So I've already told, whenever you prescribe a opioid, we already know that you have pain classes over, no? So you must have learned about morphine and opioids. We know that one of the common side effect of like opioids is nausea and vomiting. So whenever we prescribe a opioid, we should anticipate. We should be able to think that, oh, this patient might develop nausea and vomiting. So while starting morphine, you should always anticipate the need and prescribe an antiemetic. Okay, most of the time we give metoclopramide. For when we start morphine, we give metoclopramide. I tell the reason later. Use adequate and regular dose. You should not give, when you get vomiting, you take one dose. Not like that. When a patient is having vomiting, you should be able to tell them you should take a regular dose for few days, maybe for 3 days. And then the vomiting subside and you can take SOS dose later. So you should not give underdose or over. You should use adequate dose, and you should be able to give a regular dose. And think about the receptor involved. And sometimes you can use combinations if necessary. There is nothing like if you write one particular antiemetic, you can use only that. Sometimes when the vomiting is not controlled with one antiemetic, you can combine. Okay, you can give combinations if necessary. Anticipate alternate route. If one method is not working, you can switch on. You can try switching to other. So the one thing you should keep in mind is always anticipate. Whenever you prescribe opioids, you should be able to think that patient might develop vomiting later, and you should give antiemetics while prescribing opioids. Okay. Next slide. So now we'll learn in detail about the common antiemetics, their problems, their dosage, and okay, what are their action and. So the first one, next slide. Dopamine antagonist. The common dopamine antagonist we use is metoclopramide. Okay, this is very commonly used, and it acts by three mechanisms. Look, it has three action. Already it has D2 antagonism, D2 antagonistic property. D2 blocker is example is metoclopramide. It has a slight 5-HT3 antagonism also. See, it is providing a little bit of 5-HT3 antagonisms, helping to action. And the third one, cholinomimetic action. That is, it has a prokinetic agent. We know that how in when we use opioids, it causes gastric stasis, right? That is why when we take opioids, we get nausea and vomiting. The opioids can cause gastric stasis. So when we use metoclopramide, it has a prokinetic action. It causes the movement of bowel, right, our alimentary canal. So that in that way also it will help. That is why when we that is the reason why we prefer to give metoclopramide when we start morphine. Okay, it induces peristalsis and push the gut forward and helps in preventing gastric stasis. Okay, the total dose is around 330 to 120. We start with 10 milligram TDS. So when you start morphine, when you start morphine, you should give metoclopramide 10 mg TDS at least for 3 days. Initially, they'll be having vomiting, later it gets settled. So whenever you start morphine, you should prescribe. First thing is laxative, right? We'll always write a laxative along with morphine or opioid. Along with that, you should be able to give this also. The action of metoclopramide lasts for nearly 6 to 8 hours. That's why we give it as 6th hourly or 8th hourly. Okay, regularized dose. Action after like 6 to 8 hours, it will get excreted. So that's the reason why we give it as TDS means Q 8th hourly, right? We can give metoclopramide 6th hourly also. If the patient is having vomiting, severe vomiting and all, if he is tolerating orally, he can give 10 mg TDS, like 6th hourly also. So now you have learned about metoclopramide, right? D2 antagonist. Opioids. When you give opioids, the D2 receptor, the dopamine receptor in the CTC is affected. So you are blocking something in the D2, and that is a D2 antagonist. And the example of D2 antagonist is metoclopramide. Metoclopramide has so many properties. It is having cholinomimetic action also. That is why we use it along with opioids. Next slide. Now haloperidol. Look, one of the example of D2 blocker, another example of D2 blocker. It is a haloperidol. What is haloperidol actually? It is an antipsychotic, right? So you see a patient with like malignancy and the care sheet in their case sheet, you see an antipsychotic. You should be able to think, this patient is having some psychiatric illness. Is it like that? No, the patient might be having vomiting and they might have written it for controlling like vomiting. So you should be able to know that haloperidol has a property to control vomiting. It is a D2 blocker. You should be able to tell somebody else. If they are thinking like that, you should be, no, it is not like that. Haloperidol has an antiemetic action also. Yes, it is an antipsychotic, but it has some antiemetic property also. If the patient is having morphine-induced vomiting, initially starting we give metoclopramide, but the patient is continuously having severe vomiting and all, more like we can give haloperidol because it directly acts on CTZ. Haloperidol, we already told patients chemical causes in uremia, renal failure, hepatic failure, acidosis, toxins and so on. They directly act on CTZ, right? All these causes uh, nausea vomiting. So we can give haloperidol in that case. We can give 1.5 milligram up to 5 milligram in a day in such cases. A single dose might be enough if the patient is having severe vomiting due to all those features. Next slide. Now, document the likely causes. See, sometimes things may not be like the way we think. Okay, so you should be having certain differential. You think that the vomiting is due to this one, you start an antiemetic and review the patient like after 24 hours or something. If it is not like settling, you should be able to think about other diagnosis also. Patient will be having so many problems, right? So you should not like stick on this is causing the problem and only this antiemetic can be. Nothing like that. You should have a document. Like you should like think about other diagnoses also. Okay, could be because of raised ICP, maybe drugs, biochemical causes. You should try, if it is not responding to antiemetic, you should be able to change it. Next slide. Also, rule out other causes. Sometimes there will be severe pain, there will be infection, cough, hyperglycemia, anxiety, constipation. All these can be also cause nausea. These are correctable factors. Infection. Sometimes if you control the infection itself, the nausea reduces without even taking an antiemetic. Constipation. The bowel is not opening. There will be fullness in the abdomen. That might be causing nausea vomiting. And if you are if you are not treating the constipation and you are simply giving medicines for vomiting, it will not control. It will not get control. You should be able to correct the constipation. So you should know about the other causes. We always study in palliative care, no? Correct the correctable, right? You should be able to correct the correctable first. If you have an infection, correct it. If you have severe pain, you should be able to correct it. If you have anxiety or constipation is very common. Okay, should be able to correct it. And then also, if it is persisting, we can continue our antiemetic. First, you should be able to correct the correctable. In every scenario, and if it is pain or any other symptom, look for correctable factors. Next one. So again, same thing. The most appropriate based on receptor, write the stat dose, regular dose, and SOS dose. This is important. Okay, patient is coming to your OP with severe vomiting. You should manage the vomiting there. You can give a stat dose. You can give something there when he comes to hospital. Then you can give regular medication. Send him home with regular medication and always tell them about this breakthrough vomiting. Even if they take medication, they might get 1 or 2 episodes of vomiting. That is called as breakthrough vomiting. And for that, you have to give SOS doses. Not like you give the medication, send them back home, 1 or 2 episodes, they call you and tell, doctor, your medicine is not working. I am getting vomiting again. That's not right. You should be able to tell. See, you can get breakthrough vomiting when you take medication. Hmm? You take the SOS dose. So write the stat dose, give something there, write the regular dose, send them home, tell them you can take SOS doses. And choose parenteral route if continuous nausea and vomiting is persisting. Next slide. So the example of like a single antiemetic, I told no combination can be used. Single antiemetic may not be if the patient is having a raised ICP and uremia. Look, for raised ICP, we know steroid. Dexamethasone is the common steroid we use because it is long-acting. It has so many properties comparing to hydrocortisone. So what we use here is dexamethasone. It's a steroid for reducing the intracranial pressure. Patients having space-occupying lesion and all, but it is associated with uremia. You can give dexamethasone and haloperidol. Okay, fine. Next slide. So again, the summary of the class. So when the patient is having a drug-induced, opioid-induced, the patient is vomiting after like taking morphine. You can give a haloperidol, 1.5 milligram. The dosage is very important. 1.5 milligram HS or 1.5 to 2.5 milligram HS or BD. Now, radiotherapy, already told, Cetron. Cetron is serotonin, receptor blocker. And ondansetron, you can give 8 milligram stat or 4 milligram TDS. For chemotherapy, induced vomiting, you can give ondansetron 8 milligram stat and 4 mg TDS. Next, next slide. And for metabolic disorder like liver failure, renal failure, all those things, you can give haloperidol. Understood? Now, raised ICP. Again, I'm repeating it so many times that goes into your brain. Hmm? Raised ICP, you give dexamethasone. And when there is delayed gastric emptying, gastric stasis, you can give metoclopramide. Opioids causes gastric stasis, and you can give metoclopramide. When there is a gastric irritation caused by NSAIDs, we can give PPI. It's not PI, PPI. proton pump inhibitor like pantoprazole. Next slide. So same thing, different mechanism in opioid-induced vomiting. Different mechanisms are involved. We know that the opioid will stimulate the CT set, the vestibular activity, stasis, constipation, everything. Since we are using opioid commonly, this should be kept in mind. Okay, drug of choice is either metoclopramide. When we are starting, we can give metoclopramide, and if it is persisting, the vomiting is persisting, and all, we can give haloperidol. And always prevent with initial antiemetics when you prescribe opioids. Tab metoclopramide, 10 mg TDS and SOS. Next slide. Anxiety-induced vomiting, what we give? Benzodiazepines. Example is clonazepam. Clonazepam 0.25 or zero point 0.5 milligram HS. Lorazepam is long-acting. Okay. Next slide. So whenever you give medication, you should be able to review the patient, not just giving medication and sending them back home. Everything will be fine. Come after 2 weeks. You should review them. Okay. After 24 or 48 hours, you should be able to call them and ask, or ask them to call you back and tell how it is. Is it working? For everyone, everything will not work. And adjust, you can increase the dosage if required. If required, adjust the dosage or use combination. Revert back from oral to oral from parenteral if symptoms subside. It's nothing like you should continue only IV. You can switch to oral when patients start taking oral food. Next slide. Thank you. That is the end of the class. I think I have repeated few points so many times. It is little difficult to understand this topic. At least if you remember that there are few mechanisms and every drug is like not one, just it is not just one drug. That should be there at the end of the class. Okay, hope you have understood something. You have to read it again and again. You will not understand it with one class. Okay, you will have doubts. Now you can ask doubts if you have any doubts here.
Thank you, ma'am, for the wonderful session. Anybody have any doubts?
Hi, I'm just a curiosity. Do you all use levomethomazine? Hello?
Yeah, ma'am.
Sorry.
I'm just curious if do you all use levomethomazine in palliative care?
We don't use it very commonly, but it can be given. We don't
Okay.
use it commonly here.
All right. Thank you.
No questions. I hope your presentation is clear to everyone, ma'am. So unfortunately, we
That's a
don't
huge
have
success rate.
we don't have any case presentation today. Before wind up the session, I would like to highlight few things. As ma'am said, whenever you have seen a patient with nausea and vomiting, you have to do the proper assessment and identify the cause and try to manage the patient with the non-pharmacological measures first, and then you can think about the pharmacological management. Now you learned about the different receptors and different types of drugs which we are using for controlling nausea and vomiting. So now you understand the importance of the difference between the metoclopramide and ondansetron. So we used to use ondansetron for chemotherapy induced vomiting, but other vomiting we used to give a metoclopramide. But nowadays, most of the time, whenever one patient is suffering with vomiting, it is used to prescribe ondansetron. But that is not a good practice. That you have to understand. So chemotherapy-induced vomiting, that the drug of choice is ondansetron, but you have to think about the receptors, and so that is also keep it in mind all the time. Okay, and also NSAID. So the gastritis is one of the most common side effect the patient is using NSAID. So proton pump inhibitor. So that is also a very important. And another important thing is whenever you have seen a patient with NSAID, you have to educate the patient about the importance of taking food. After taking food only, they have to take an NSAID. And also they have to take a plenty of oral fluids also. So one NSAID can cause acute renal failure. So they have to take a plenty of oral fluids also. These are the two important points you have to keep it in mind. So I think we can wind up. If you have any questions, we can take it up. Otherwise, we can wind up. Ma'am, shall we wind up?
Yeah, Sister J. They don't have doubts. We can wind up the
Okay.
class.
Okay, thank you, Dr. Nayana, for the wonderful session. Thank you, Sister Sheba, for the wonderful facilitation. All the I was watching all the participants. They were keenly listening. Thank you for that. Till we meet. Bye.
Thank you. Thank you all.